Welcome to today's session, sponsored and put on by the East Texas Geriatric Education Center, addressing difficult topics in aging and disease. This is session 3 that will focus on everything you need to know about cancer. I would like to acknowledge our partnership with the East Texas Area Health Education Center East that have been really valuable in terms of our collaboration and distribution and connections with our consortium partners in East Texas. Okay. This is, as I said, the third session. It's in a series of 4 dealing with these difficult topics. And when you want to look at it, it is really about challenges to working with older patients and disease processes. And we will have our final session on the 3rd Wednesday in May 16th, looking at modeling long-term care that will focus on nursing home residents and older prisoners. And we hope you can make it then as well. This will be a very short introduction because we have a lot to do today and a lot to fit in 3 hours. And everything is in your handouts, so I'll just briefly go over this so we can get going here. You have your agenda here with our 5 speakers, and this will cover the whole gamut of cancer care with an overview of basically epidemiology of cancer given by Catherine Coaxley, then looking at screening with Dr. James Goodwin, treatment of cancer with Dr. Holly Holmes, a short break, and then to kind of go along with treatment, what about overtreatment or aggressive treatment? And this will be given by Dr. Gulshan Sharma. And finally, with Dr. Linda Elting, supportive care, not just for treatment for end-of-life care, but this new wonderful area of survival of cancer. Okay. And this will also be set up now as a webinar, and I will give you later on, those that are connecting as a webinar, the number to call in for questions and answers. Okay. The whole day has a list of learning objectives, which are listed here and in your handout. And we teleconference to our 5 of our consortium partners in Lamar, University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor University in Waco, Victoria College in Victoria, and Weatherford College in Decatur. Okay, there's lots of information available for CME. These are all free credits for doctors, nurse practitioners, and physician assistants. I need to disclose that all except Dr. Linda Elting have no commercial financial interests or affiliations to disclose. Dr. Elting discloses the following relevant financial relationship with Helsinn Pharmaceuticals in terms of having grant and research support. And the same for nursing with CNE, similar disclosures, and all the paperwork evaluation forms are in the back. Physical therapists, we have CEUs available as well as for occupational therapists. Okay. This is really about CERSIT, Comparative Effectiveness Research in Cancer in Texas, and all the speakers are affiliated with CERSIT. And you can find out more about this work being done, this collaborative work, which has been wonderful because we've been bringing in other researchers from MD Anderson, Rice University, University of Texas School of Public Health, and Baylor College of Medicine, and the Texas Cancer Registry.
Okay, so when you do survivorship and in particular supportive care research, you know that you're always the last person on the program, unless it's a morning session, in which case you're on at 6 a.m. before anyone arrives. So I'm going to do my best to have you out of here by 3 o'clock or when you develop a DVT from sitting for so long. So I'm defining supportive care here as separate from what you might think of as palliative care or end-of-life care. And what I do research in is managing and preventing the adverse effects of treatment of cancer. So there's a very fine line there, but it's a distinct one. Most of these adverse effects arise acutely, although some late toxicities do arise. and are quite chronic. And one of the unique and very cool things about doing supportive care research is that you look across the whole continuum of care from the time of diagnosis on through survivorship. And so this is an interesting field of research. So there are some reasons that this is important, and in particular, we worry, those of us who think chemotherapy is a good thing and aggressive treatment is a good thing in some populations, that adverse effects can limit the neoplastic treatment and the dose. Our goal, if a patient is fit enough for treatment, is to keep them on schedule and on dose, if possible, because those doses and schedules were chosen for a reason. If adverse effects occur, it's necessary to stop or delay or reduce doses that may be negative in terms of survival. If that happens, then all the negative things that happened to them so far were for naught. So if we made a good choice, we got a fit individual, but they have toxicity that's so severe, then we have wasted their suffering through their nausea and vomiting. And we try to prevent that so that we can treat aggressively inappropriate individuals. Serious side effects, even annoying side effects, adversely affect compliance with treatment. This was brought home most dramatically to me when I first started in cancer research. We had a testicular cancer patient, classic 21-year-old guy at the University of Texas, not Lance Armstrong. And he came in, we gave him the best treatment available. It was of curative intent, and it probably would have cured him. But his mucositis, his mouth sores, and his nausea and vomiting were so severe, he walked after the second cycle of chemo and later died. And it all had to do with the side effects. Today, we could have done a better job of preventing those side effects. And finally, adverse events affect the quality of life and functional status. Cancer now is a disease that's treated 90% of the time in the outpatient setting. Our patients leave the clinic from getting chemo and go to work. And so if we can't prevent their adverse events, the nausea and vomiting acutely and then other things, this disrupts the lives of our patients even more. So what we try to do is prevent those things. So how do we do that? Well, first of all, we make a long list of everything terrible that could happen to a person during chemotherapy, and these are only the common ones. There are many more that are far more severe, but thankfully very rare. And so we try and figure out what these things might do and how they might affect patients. And as you can see, it's all kinds of different systems in the body. It's all kinds of different specialists if you want to call somebody in when there's a problem. And these can be very serious problems. And we try to examine these things, but we often run into barriers. And so the first one is that we have a whole lot of specialists who spend a lot of time in medical oncology or radiation oncology or surgery school learning how to do definitive treatment and do it great. They spend a lot less time learning about how to prevent and how to treat the adverse effects. Now, if you're at MD Anderson, you call Holly, or you call an ID specialist or someone else. But in the community, there are a lot of individuals who aren't aware of the newest drugs or newest preventive things that have been managed for patients. The outpatient onset of toxicity is one of our biggest barriers. Our patients get their drugs or they get their radiation and they go home. And so the adverse events may happen when they're at home. And what we find is that providers don't ask and patients don't tell. And so by the time they get back, they've recovered from their chemo, they have recovered from their nausea, their mouths aren't sore anymore, and the physician said, how'd you do? And the patient says, fine. Now they have often told me just before that, I vomited for 4 days. My husband stayed home from work to take care of me. Then I got an infection and my mouth was so sore I lost 5 pounds and I'm starting to gain it back. And when the physician walks in the room, they say, oh, I did fine. And I've asked patients after that, why did you say that? Why didn't you report? There are 2 reasons. Some of them use one or the other. Many use both. Number 1, I want that doctor to focus on curing my cancer and not think about anything else. Number 2, I don't want them to reduce my dose. If they reduce my dose, I'll die. So that's a problem in having these things occur as outpatients. There's a wait-and-see strategy that we use in these days when drugs and preventive agents are fabulously expensive. And that wait-and-see strategy is, well, we know that this toxicity occurs in only about 30% of patients. And this prevention is pretty expensive, and 20% of it is still pretty expensive for the patient out of pocket. Let's wait and see how they do with cycle 1. And if they do terrible, then we can prescribe the preventive in cycle 2. So that's a barrier to getting prevention methods used. And finally, there's just acquisition cost. New drugs are expensive drugs. And when you add them on top of the cost of new chemotherapy drugs which are fabulously expensive, many patients can't afford it. So how can you help? So I like to tell people, equip your patients. And number one, educate your patients. They need to know what to expect about adverse effects, truly, honestly, if they don't take the preventive and if they do take it. They need to know what to expect from the preventive treatment. So 3 decades ago, when patients came to our clinic, I would tell them, this drug, cisplatin, is going to make you vomit. 100% of patients vomit at this dose. It will likely make you vomit for 3 days. If it gets so bad you can't take it, we will put you in the hospital, put an IV in your arm, and we'll give you a drug that puts you to sleep until you get past this, which is about the only antiemetic we had then. Today we tell them, if you didn't take this drug that we would like for you to take as preventive, you would vomit. If you take it, it's almost certain you will not. You may have mild nausea. You will be able to leave the clinic and go home, rest for the day, and go to work tomorrow. They need to have that information to make educated decisions about whether they fill the prescription and whether they decide to take the drug. They need to know what to expect from the side effects of those drugs we use as preventives. And we have to educate patients to report symptoms even after they've resolved, so when they come back to the doctor. So how are you going to accomplish this? You're a busy primary care provider, you're a nurse or a physician or a social worker, you're seeing patients in the office and you're spending half of your time keeping up with developments in cardiovascular disease and half in cancer. How do you do this? I recommend that whenever possible, you borrow whatever you can. And so I like to use this reference, which is called OncoLink. It's from the University of Pennsylvania. You can go to their website, and in your slides, the website is on the last slide. And this is printable from the web, and it tells you about the side effects of all kinds of treatments. And what I like about it is it tells you what the side effect is and how it would make you feel, what causes it, gives some ideas about how to prevent and manage it, tells you what you should avoid. And it's clearly been the result of many years of experience, because one of the ones I like the best is the one that says avoid your favorite foods during bouts of nausea and vomiting so you won't associate them with feelings of nausea later on. This is something I tell patients all the time, but often that's not told if you don't see a lot of patients who get chemo. How are they treated? Lots of suggestions about that. It says don't take medicines unless your doctor or nurse has advised you to do so. And importantly, when to call the doctor. And at the end, be sure to let your doctor or nurse know your symptoms so you can prevent any complications, and it should say from arising in the future. But I think these work very well. They're printable. You can download them as PDFs and email them to patients, and they're free. So you don't have to steal them, they're actually available. So in addition to educating, you have to ask patients, and you have to be specific. If you just say, how did you do? You may not find out the side effects and symptoms that patients had while they're away from you. But always ask also an open-ended question, because some people have completely unique experiences with chemotherapy, as with any drug. Ask early and often. You sometimes have to ask 3 times about some symptoms before they'll actually tell you the truth. You know that. and tailor questions to the expected toxicities based on what treatment they're getting, but also the stage of treatment that they're in. So I've listed here, taken that list we had before and changed them into those that occur immediately with an infusion or with radiation therapy, early on, say in the 1 to 2 weeks after the initiation of definitive treatment, and then the late effects that we monitor for and look at. And so how do we do this and actually operationalize this? Again, steal what you can. Here's an example of a tool that was developed by a group called MASC, the Multinational Association for Supportive Care in Cancer. It's downloadable from the web in 11 languages. It's a tool that facilitates communication between patients and doctors about side effects they're experiencing. This one is very simple. It's for nausea and vomiting only. 4 questions to fill out on the first day after chemo and 4 questions on the 4th day after chemo. The goal of that is to identify both early and late onset of vomiting because we prevent them with different kinds of drugs. Here's what it looks like. Hopefully you can read it on your pieces of paper. Very simple. You fill in the day and the day of the week and the date on which they should fill it out. They check off boxes and put in the information in the scale, and then the instructions tell them to bring it back when they see the doctor the next time. So additionally, we need to prescribe. When I first started doing supportive care research 35 years ago, there weren't many things we had available. There are a lot of great preventive treatments and treatments now, and even treatments that work for breakthrough symptoms. And so we need to encourage our patients to use them, but we also need to prescribe, and we're not always good at doing that. Here's some information from the CIRCIT study that looks at adherence to the guidelines for prescribing anti-emetic drugs in patients, elderly Texans with lung cancer who are getting cisplatin. As you can see, compliance is not ideal. Around 80 or 90% of the time for some years, but there are between 10 and 15% of patients who don't receive the recommended preventive anti-emetic. This is an immediate toxicity. Here's an example of one that develops about 2 to 4 weeks later. Patients get low blood counts and then they're at risk for infection. Elderly patients who receive aggressive chemotherapy are recommended to have growth factors prophylactically immediately following their chemotherapy. As you can see, in Texas, only about 5 to 8% of patients receive that during cycle 1. What we think happened in 2001 and 2 is that a couple of very important papers were published in the New England Journal that said while the growth factors prevent infections, they don't increase the dose intensity or improve overall survival. And as you probably know, women who have been treated for breast cancer often receive hormonal therapy after their chemotherapy, often for up to 5 years if you're using tamoxifen. Because those drugs have a tendency to cause bone loss, bone mineral density is recommended at baseline and then about every 6 months to 1 year after that during the treatment. In Texas, between the years of 2000 and 2007, again, not even half of the women who were receiving these drugs had the recommended screening for late effects of chemotherapy. That's an important omission in these women because many of them are probably cured of their breast cancer. They have long lives ahead of them and we need to guard their bone health. It's also important because when you look at survivors, elderly cancer survivors in particular, and you compare their health status to the status of comparable people in the general population, you find that they report many more days per month in poor health than their cohorts. And you can see that it's a substantial amount. They actually report the same number of comorbidities, but far more days in poor health. And these are survivors who are more than 1 year out from treatment. So most are not receiving treatment anymore. They're now in the survivorship, many of these 5 and 10 years out, but their health status is not as good as their age-matched counterparts in the general population. So how are we going to accomplish this prescribing? Again, I recommend you steal what you can. What I like, even more than the guidelines, where you have to find guidelines for lots of things, if you go to nccn.org, you can download what they call order templates for various chemo regimens. And they begin by telling you this is a regimen for lymphoma patients with poor left ventricular function, so this is a regimen that would likely be used in the elderly, and the emetic risk is moderate, fever and neutropenia risk is high. They then give you recommendations about how to write the orders to administer the drugs, mentioning that you need to increase hydration in patients who get cyclophosphamide. And they include supportive care orders, so you don't have to look separately at the guidelines for supportive care. They list the pre-medications for Rituxan and then the antiemetic therapy, including prescriptions that should be given, PRN for breakthrough antiemetics. No need to go to multiple guidelines or anything. You can download these easily. They are tailored to each chemotherapy regimen. So if you're a patient that you see in a primary care practice has received a certain regimen, you can download those order templates, and it makes it very easy to operationalize the supportive care. And they even tell you how to give growth factors, which ones, and the various kinds of additional supportive care that may be necessary for the less common things that might be seen. So the take-home messages: educate your patients, educate their family caregivers. You know as well as anyone that when a bad diagnosis, the day that it arrives and the day you tell them about the treatment, all kinds of things get said and forgotten or not realized. Educate the family too. One of the reasons I like those tip sheets, they call them, from OncoLink, is that you can print them and send them home with the patient and the family. So they have something in their hand to take with them with lots of answers to their questions that will come up. You have to ask, query about side effects early and often and how severe. Prescribe the recommended preventive and therapeutic agents, and whenever possible, use the resources that are already available in the public domain. Don't reinvent the wheel. Here's a list, and those are in your handouts. I find that for cancer survivors, which may be common in your practice, one of the best websites is the Live Strong website, Lance Armstrong's website. They have survivorship care plans there that patients and clinicians can work through together, but in particular, patients and family members can work through, and so those are great resources to use. As I said, I like the OncoLink tip sheets. Everybody who makes guidelines for providers also makes patient guides for the patients who are receiving those treatments. You can download those from many of these sites as well. And I will thank my collaborators in this work. That may be a record. Well, it was deliberate because of the time involved. Much of the literature on, for example, exercise, guided imagery, which is effective in some patients, acupuncture, which acts really well, particularly nausea and vomiting, it's very effective. Much of the literature is controversial. And so to present that to a group like this, I would have to present both sides, and it takes a long time. There is a lot of data out there on support groups. It's not supportive of support groups. But the literature is very supportive of nutrition. One of the reasons I like the OncoLink is that it includes all those kinds of things and recommends many of the other methods that we use to control side effects and symptoms. And in fact, they're very effective in side effects and adverse events that are not severe. they eliminate the need to treat with a medicine that may have other toxicities. We have a full range of acupuncture folks at MD Anderson. They're busy full-time with patients like this. Actually, what we find when we look at adherence in community practices is that it's very common in for example, a 3-drug prevention regimen for adherence to be very high for the most expensive drug and adherence to be 0 or very low for something cheap like prednisone. So it's not always cost that's active. It's also, when we look at adherence, we usually have less clinically rich information than we would like in order to evaluate whether a person truly should have received it. So obviously adherence sometimes looks low because there are patients out there who have a history of ulcers, so they don't want to give them prednisone or something like that. We find that in large community practices, it's very common that nurses are trained to do all kinds of counseling, training for guided imagery, for many of the training on nutrition and training on exercise. We find less access in hardly any place except hospitals to acupuncture, which is actually very effective. With respect to the more expensive preventive agents, we have lots of success in getting free drug for patients who can't pay. And this is available, but you only get it if you know to ask. And I think there are many, particularly patients who are treated in practices that are not full-time cancer practices, who don't receive that benefit. So there are, what I have discussed today are only the commercially available drugs that are in common use, and in fact many of them are available generically. So they're not terribly expensive. The growth factors are the exception. Nobody, I think, has really figured out how to do biosimilars in this country anyway. So, but the other drugs are all commercially available.
Sure, my pleasure.
Thank you all for being here.